that it's the new kid on the block. It's called anakinra, and for those patients that are actually totally unresponsive to the TNF alpha blockers, that's the next step. It's a very expensive medication. I've never used it. I've never seen any of my patients on it. But just so you guys know, that's actually the most the novel thing in rheumatoid arthritis. And there are other medications that are not necessarily FDA approved, like rituximab. It's off-label FDA for arthritis, but some rheumatologists use it. And leflunomide, which is Arava. But the problem with Arava is that it can cause hepatotoxicity, and sometimes it can be very serious hepatotoxicity. So most rheumatologists try to stay with a little bit of methotrexate and one of the TNF alpha blockers for management of severe rheumatoid arthritis. You guys figured out limumab? And which one is the other one? The infliximab?
Oh, sorry, I looked at the anakinra.
Infliximab is? Remicade, yeah. Remicade. So Remicade, Humira, or Enbrel. Those are the three FDA-approved biologics for rheumatoid arthritis. So the non-biologics, the Plaquenil, you use it for milder disease because it's a safe side effect profile. You can use it in pregnancy. It's actually one of the few things that you can do throughout pregnancy. My wife was taking it throughout the pregnancy. We just had a baby girl 2 months ago. And thank you. Yeah, and then she did very well. Fortunately, nothing really bad happened. So for your pregnant ladies, this is the treatment of choice. Prednisone. You know what prednisone can cause in pregnancy? You guys remember? It's not teratogenic, but it can cause actually growth restriction. So, especially in the second and third trimester, the patients, they need to be monitored for growth restriction. But a lot of patients suffering from rheumatologic conditions, they have to be on prednisone. It's not a contraindication, but that's one of the possible side effects. And remember to refer your patients for an ophthalmology exam, because Plaquenil, if it's already accumulating, you have to stop it. There's no other way of fixing this problem. If you keep using it, or if you don't check, patients can actually develop permanent retinal damage. So make sure that you may get asked this question on your boards, because it's pretty standard of care. So the sulfasalazine, it's also used like for milder disease, and these patients, most of the patients have like some sort of GI side effect, and that's one of the things limiting. The problem with sulfasalazine is that it oftentimes requires like a large dose of these medications, so the patients get pretty tired of using so many pills. And methotrexate continues to be like probably like the mainstay of therapy of rheumatoid arthritis. You have to be very careful on renal and liver disease, or consistent alcohol use, because you can use it on these settings. You're going to look for bone marrow suppression, as a form of pneumonitis that is rare, but if you ask the patients about pulmonary symptoms that they're taking it, you better investigate further, because patients can actually have progressive pneumonitis. And we prescribe it along with folic acid, like you were describing, because or folinic acid, which is like 50 times more potent than just regular folic acid. Because the patients, one of the known side effects from methotrexate is a form of stomatitis. So patients can actually come with like severe ulcers. I've seen it twice, and it's pretty painful. Like, just imagine like the mouth full of like canker sores. It's quite painful, and it's not a serious side effect, but like we know that supplementing patients with folic acid can reduce the risk of developing this complication. And the biologics, typically you don't stop the methotrexate. They're most beneficial when you combine them with methotrexate. And the bigger complication is infection. On your boards, you always have to remember that you need to check a PPD on this patient, either a PPD or quantiferin gold. You cannot prescribe this medicine if you don't have clear documentation of negativity. If you have latent TB, if you give these medications, you can kill someone from disseminated TB. So make sure that you guys, it's actually one of the most serious side effects from this group of medicines. And always remember that these medications can actually cause drug-induced lupus. Which is the test that you guys ordered for drug-induced lupus? Yes, remember? No, the Smith is for lupus. It's for lupus, but antihistamine antibody. Antihistamine antibody. So drug-induced lupus. Remember, what are the drugs that can cause drug-induced lupus? Procainamide. What else? Hydralazine. I've had 2 cases in my career. Isoniazid. Yeah, those 3, and the biologics. The biologics can cause that as well. Interestingly, drug-induced lupus does not involve the kidneys. Believe it or not, it's just like systemic, like arthritis. But one of my patients had a pretty dramatic case of multiple joint involvement from hydralazine. And the longer you use, or the higher the dose, the more likely you're going to end up developing these autoantibodies, antihistamine antibodies. Okay, why don't you help me with the next case, please?
23-year-old evaluated in emergency department for 5-day history of headache, blurry vision, right eye pain. His eye pain increases when he attempts to read or when exposed to light. He also has a 3-year history of back stiffness that is worse in the morning, tends to improve as he becomes more active. He does not have arthralgia, arthritis, or rash. He takes no medication, is monogamous. On physical exam, temperature is 36.8, blood pressure 130/76, pulse 85, respiratory is 14, no skin lesions, appearance of the eye is shown. Photophobia is present during the pen light exam of the pupil. Both pupils react to light. Emergency referral is made to an optometrist. Following resolution of the eye problem, the patient should be evaluated for which of the following systemic diseases.
Which one? Ankylosing spondylitis. Any other takers? Sarcoidosis. Yeah, so it is ankylosing spondylitis. So quick point for those of you working at urgent care. If you had a patient with a red eye, and things that you need to ask is crusting, because crusting is more likely associated with some sort of viral or bacterial conjunctivitis. You need to ask for photophobia. If you have patient has severe eye pain and photophobia, just don't assume this is conjunctivitis, because you're gonna be wrong. If the patients are complaining of photophobia or severe eye pain, you better believe that they have some sort of uveitis, and these patients, they need to have an extensive rheumatology workup, because it may be one of these systemic diseases. But in this case, it's more likely to be spondylitis, ankylosing spondylitis, and they may give you another scenario on your boards, like, how do they used to call that? They used to call it Reiter syndrome, or how do you call it?
Yeah.
Like urethritis, and I think we no longer call it that. We call it reactive arthritis. Because I think that guy was some sort of Nazi, or I don't know what the story is. I hear different stories, but we're trying to move away from these eponyms. We're just moving like towards more like a descriptive, like physiopathology descriptive way of describing the disease. All right, please help me with the next one.
24-year-old woman is evaluated for a 2-week history of persistent pain and swelling in the right foot and knee and the left heel. 1 month ago, she developed an episode of conjunctivitis that resolved spontaneously. She also had an episode of severe diarrhea 2 months ago while traveling to Central America that was successfully treated with a 3-day course of ciprofloxacin and levothyroxine. She has not had other infections of the gastrointestinal or GU tract, rash, or ulcerations. Her weight has been stable and she has not had abdominal pain, blood in the stool, or changes in her bowel habits. She has had only one sexual partner 6 years ago. She otherwise feels well and has no other medical problems and takes no medications other than acetaminophen for joint pain. On physical examination, vital signs, including temperature, are normal. Cutaneous examination, including the nails and all mucosa, is normal. There's no evidence of conjunctivitis or iritis. A scan examination reveals swelling, warmth, and tenderness of the right knee and ankle. There is tenderness in our patient at the insertion side of the left Achilles tendon.
What do you think? Reactive arthritis. Very good. Okay, so when you hear like involvement of the tendons, you think about, we call that enthesopathy, and when you think about, seronegative spondyloarthropathies, So there's a genetic predisposition. I think these patients are positive for HLA B27, right? So there is usually an infectious trigger, either like a urethritis or some sort of like GI, like the case that I just described. And if you see the inflammation of the tendons, you think about it, and you also think about the extraarticular involvement. So this is a classic picture of a person with ankylosing spondylitis. Before these new monoclonal antibodies, this disease was actually a pretty bad disease to have because they were very unresponsive to conventional therapies. But again, these medications were really game changers. Make sure you look for the bamboo spine on your board picture. So these are the four ones that we classify as seronegative spondyloarthropathies. AS is usually males. The pain is better with exercise. They may show you a bamboo spine. They have extraarticular manifestations like including uveitis, aortitis. They may have restrictive lung disease. And when they have like lung disease, it's actually worse prognosis because these conditions can actually be progressive. And the treatment is with DMARDS and biologics, like I mentioned. So the reactive arthritis, these patients, like, they have like what they call like the riders, is the urethritis, conjunctivitis, asymmetric arthritis. Like this person had like a knee and some sort of ankle. And these are the pathogens that are more commonly associated, but sometimes we can't even isolate a pathogen and you can still have the reactive arthritis. The treatment, unlike AS, these patients, they get treated with NSAIDs. You don't give biologics. You just need to treat the underlying infection, whatever it is. So make sure you don't get it wrong on your boards because the management is very different from one from the other. So the enteropathic arthropathy, so it's usually peripheral joint involvements, and they can have like spine and the sacroiliac joints. And these patients do get treated with sulfasalazine because sulfasalazine may control the peripheral joint disease, and they may also control the GI symptoms. But when it's not sufficient, you think about anti-TNF or methotrexate when they're having severe symptoms. And lastly, the psoriatic arthritis. You look for the typical skin and joint involvement if they give you a question like that on your boards. And the important thing to remember is that we don't use Plaquenil for psoriatic arthritis. It actually makes the disease, the skin manifestation, worse when you use it. So these patients are invariably treated with biologicals. All right, help me please with this one.
A 70-year-old male dairy farmer is evaluated for a 1-year history of pain in the left knee that worsens with activity and is relieved with rest. On physical examination, vital signs are normal. A small effusion is present on the left knee, but there is no erythema or warmth. Range of motion of the left knee elicits pain and is slightly limited. Extension of the joint is limited to approximately 10 degrees, but flexion is nearly full. The remainder of the musculoskeletal examination is normal. The erythrocyte sedimentation rate is 15. A standing radiograph of the left knee is shown. Which of the following is the most likely diagnosis?
What do you think? This is a classic description of osteoarthritis. So you can see like the narrowing of the joint space. Sometimes you see no space at all when it's actually bicompartmental arthritis. But it's typically, this is actually one of the most typical early involvements in the medial joint, the medial tibial joint. How do you call this joint? The tibial. The tibial plateau. Yeah, like loss of the cartilage in the space, narrowing of the space. Typically, you hear that the patients have a very long-standing history. Most of the times, they're elderly or they're obese, because that's a risk factor for both. It's the wear and tear type of arthritis. They may give you some inflammatory markers that are completely normal, like ESR of 15, and limited range of motion when they give you the description. So distinguishing inflammatory versus non-inflammatory is an important tool when you're confronted with a rheumatology question on your boards. So typically you look for warmth, erythema, and effusion in inflammatory, but you see actually the opposite. You don't see no inflammation, and perhaps you see some bony proliferation in osteoarthritis. So in the morning stiffness is more pronounced in the inflammatory versus like less severe in the non-inflammatory. Patients tend to have more systemic symptoms when they have a rheumatologic underlying inflammatory condition, and the synovial fluid looks very abnormal, whereas it's pretty bland, if we can call it that way, for the non-inflammatory arthritis. And the X-ray, definitely you can see erosions. That's why I want you guys to concentrate on looking at the X-rays versus more of chronic changes like osteophytes and subchondral sclerosis for the patients with osteoarthritis. Okay, can you help me please read the next one?
At 67-year-old man comes for evaluation and knee pain. 2 months ago, he developed pain in the right knee that worsened when he played tennis and was moved with rest. He now has pain with most activities and occasionally at rest that's often associated with swelling. He has no warning symptoms. Monthly associated symptoms that are only mild to moderate relief of pain. 1 year ago, he was diagnosed with coronary artery disease with a mild myocardial infarction and underwent intracoronary stent placement. He also has hypertension, hyperlipidemia. Current medications are atorvastatin, atenolol, isosorbide, mononitrate, and low-dose aspirin. On physical exam, blood pressure is 130/80. Cardiac exam shows a S normal S1 and S2 and no murmurs or rubs. Range of motion in the right knee is painful and limited. The remainder that musculoskeletal exam is normal. Radiograph shows medial multidisciplinary subchondral sclerosis of arthritis. Which of the following is the most appropriate next therapeutic step for this patient's knee pain?
What do you think? Celebrex? Any other takers? What do you think he has?
Osteoarthritis.
Osteoarthritis, okay.
He's only taking acetaminophen, so stage 2.
So is it wise to prescribe an NSAID, given his age and the fact that he's already taking Plavix?
Should we do the arthroscopic lavage of the right?
So when they're very clinically evident, like this guy that he has osteoarthritis, like most of the times you don't need to do further evaluation. In fact, at the primary care level, you never do an MRI for presumed osteoarthritis. You defer that decision to the orthopedics, because they will be talking to the patients whether or not they should have an arthroplasty or not. In this case, he probably cannot get an arthroplasty because, number one, he hasn't been medically optimized. Arthroplasty is the last resort. It's not something that you want to jump in and do right away, especially somebody who's already with other medical issues. You cannot stop the Plavix because he had a heart attack less than a year ago. Most of the times they keep a Plavix at least for 1 year. Some cardiologists are comfortable stopping it after 6 months, but it varies from practice to practice. And generally speaking, when you guys are confronted with an urgent care patient, the FDA recommends against the use of NSAIDs in anybody after the age of 65. Whether or not you have GI or kidney issues, just your age itself is a precluding factor for prescribing NSAIDs, because we know that elderly are more prone to develop these complications. The other thing that's important to know is that you guys probably are too young for this, but back in the 90s, the FDA had a lot of black box warnings for medication that was called Vioxx. I don't know if you guys were around when Vioxx was the new kid in the block in the US. And a lot of lawsuits actually follow when they pull it out of the market, because they demonstrated that patients with coronary artery disease or at risk of having coronary artery disease, they ended up having high mortality related to Vioxx use. So Celebrex is the only survivor from all these amazing medications that were invented in the late 1980s and widely used in the 1990s. We have like valdecoxib, celecoxib, Biox. All of these medications were pulled out. Celebrex are still there, but my advice to you guys is don't prescribe it. In someone who has high risk, in someone with kidney disease, someone with heart disease, or somebody with a history of peptic ulcer disease, and you certainly don't want to combine that with other medications that can put you at risk of having a GI bleed, like steroids or like aspirin and things like that. So tramadol is a safer medication. It's safer in the elderly. It's a synthetic opiate, and you can use it in addition to other things like what I do for my elderly patients. I refer them to physical therapy because a lot of the times these patients have a lot of abnormalities in their gait. So they may need a gait assistant device, or they may need to have like a better distribution of the weight when they walk. Or strengthening of the quads muscle. That also helps with the stability of the joint. So invariably I refer everybody to physical therapy, but also you can advise them to take Tylenol around the clock, which is safe as long as you keep it less than 2 grams in a 24-hour period. I know they say like usually never more than 4 grams, but if you have a patient using Tylenol for a long time, it's probably safer if you keep it below 2 grams a day. And I also prescribe medication called capsaicin. Have you guys heard about capsaicin? So capsaicin is very benign. You can use it in liver disease, kidney disease. It directly inhibits substance P, which is one of the neurotransmitters involving pain mediation. And you need to warn the patients that once they put on the capsaicin, they're going to feel like it's very hot. And the reason is because it's made out of the chili plant. It feels very, very hot. You need to warn them because otherwise they're going to say like, forget about it, I'm not using that again. But it also, there's a lot of actually studies showing that it's safe in osteoarthritis and is beneficial. So there's also some studies suggesting that like glucosamine and chondroitin can be helpful. The way I see it is that these are medications that are not harmful, so why not? You may tell your patients, why don't you just buy some chondroitin, glucosamine? But you can also prescribe some sort of like knee stabilizers or like knee braces for the patients. But the bottom line is that you want to be as minimally invasive as possible, and to understand that total knee arthroplasty is not the first line. It's actually the last line. When somebody needs a knee arthroplasty, you know that those are not forever. So chances are is the longer that you can delay it, the better, because otherwise the patients are going to need another intervention down the road. So the management, weight loss, for sure. Like you will be amazed how many patients come to your clinic telling you that the knees hurt, and they fail to recognize why the knee hurt. And it's probably, for us, it's probably like, duh, it's too obvious that it's your weight, but you need to explain that to the patients, because don't assume that they understand why they're having knee pain. Tylenol or NSAIDs if you can use, but nephrologists and NSAIDs, we don't get along, so I don't usually prescribe them. Second line, tramadol or opiates. Injections, you can do the injections, but make sure that you understand that you cannot do them very frequently, and also that if the patient has systemic diseases like diabetes, they may be more problematic. And if you have a patient with synovitis, you have to rule out other things. Remember, don't just assume that this is osteoarthritis, because if you have synovitis, you may be dealing with something else. And if you have a septic joint, the last thing you want to do is to inject steroids in a septic joint. You want to be able to diagnose it, and the only way of doing this is by doing a diagnostic arthrocentesis. Have you guys ever seen one? Or have you ever done one? It's pretty simple. The knee is actually one of the easiest joints to tap. There's only one way you can't miss the synovial space. And if you're in the urgent care, you have to do a synovial joint. You have to do an aspirate if you have an acute arthritis. If you don't do it, it's malpractice. On your boards, you always do a diagnostic arthrocentesis. These are the typical joints. So if you see DIPs, you think about psoriatic arthritis and osteoarthritis, the Heberden nodules. I think I have a picture here. And in In the PIPs, you have the Bouchard nodules, but you also think about RA or lupus. Let me ask you a question. Is lupus erosive or non-erosive? Non-erosive. Always remember that. It's inflammatory. You see synovitis, but there's no erosion. So if you have those two words on your boards, lupus until proven otherwise. And if you have it in the MCPs, you think about RA, lupus, or hemochromatosis. Have you guys ever seen hemochromatosis? Iron overload. Yeah. Have you ever seen a patient with this? You will probably at one point.
I don't know where his classmates have, but
He does?
he has AML. Got it from a bone marrow transplant.
Really? Interesting. So probably secondary hemochromatosis. Okay. Who wants to help me with this one? You read it? You read it? Thank you.
A 52-year-old woman is evaluated with a morbid history of swelling and pain of the left knee. She has a 6-year history of Crohn's disease associated with great involvement of the knees and ankles. Her last disease flared 2 years ago. At that time, she was treated with a 3-month course of tapering prednisone and infliximab. She has continued taking infliximab. She has also been on as a thiopnine for 3 years. In physical exam, temperature is 38 degrees Celsius, a pulse of 88, respiration rate is 18. The left ankle is warm and swollen, and passive range of motion of this joint elicits pain. The knees are mildly tender to palpation bilaterally, but do not have effusions, lump, or erythema. Range of motion of the knees elicits crepitus bilaterally. The remainder of the musculoskeletal exam is normal. Arthrocentesis of the left knee is performed and it yields 3 milliliters of cloudy yellow fluid. The synovial fluid leukocyte count is 75,000, 90%, 92% neutrophils. Polarized light microscopy of the fluid shows no crystals and gram stain is negative. Culture results are pending. Which of the following is most likely diagnosis?
What do you think? Yeah, this is actually a nightmare for urgent care doctor. The last thing you want to do is to miss something like this. This is Ramiro. So open. Ramiro.
You can't open it.
We can?
It's locked. You can't open it. It's locked.
Who is this? Oh, it's probably Ramiro, right? Oh, it's Helen.
It's family.
It's his family. It's the girls. They're looking for daddy. So, but they can go around, right?
Yeah.
Okay. He went that way, right? Okay. So, you don't want to miss this. And that's the reason why on your boards, if you have acute arthritis, you need to tap. Always. So make sure you guys know that. On your boards, they may give you, if it's a gout case, they give you the classic negatively birefringent, like needle-shaped crystals. If it's something else, they may give you have you guys heard about the crystal-induced arthritis, like the calcium pyrophosphate, the CCP? Calcium pyrophosphate is like what we call pseudo-gout. They may give you the crystals, but those are positively, birefringent. So typically it's like a middle-aged woman with some sort of like calcium deposition. But in this case, definitely, I have a slide here to show you. Okay, read the second case and then I'll show you the slide. If you can help me with this one.
An 82-year-old woman with a 2-year history of osteoarthritis disease is evaluated for persistent swelling and pain in the right knee of 2 months duration. No use of cane for ambulation and is unable to go grocery shopping. Medications are naproxen and hydrocodone acetaminophen when needed. On physical examination, vital signs are normal. The right knee has a large effusion and a valgus deformity. There's decreased flexion of the right knee, secondary to pain and stiffness, and she is unable to fully extend this joint. Range of motion of both knees elicits coarse crepitus. Laboratory studies reveal a serum creatinine level of 1.1 milligrams per deciliter and a serum uric acid level of 8.2 milligrams per deciliter. Radiograph of the right knee reveals a large confusion and changes consistent with end-stage osteoarthritis. Aspiration of the right knee is performed. Synovial fluid leukocyte count is 3,200. Polarized light microscopy of the fluid demonstrates rhomboid shaped, weakly positively divergent crystals.
results of the Encino culture has been managed to follow this diagnosis.
So you're gonna look for that magic word, the rhomboid shape, weakly positively birefringent crystals, and you think about, yeah, CPPD. So calcium pyrophosphate dehydrate deposition disease. It's also known as pseudo-gout. They shouldn't call it that way because it's confusing. So, you know, like the correct way of calling it is CCPD. So this is a slide showing like this is the how it looks. So if you see a lot of WBCs, you always think about septic arthritis when it's greater than 50,000. But pseudo-gout or CCPD, anywhere from 5,000 to 75,000. But the key thing, and that's why when you work in the urgent care setting, most labs are going to be able to report this within an hour or within 2 hours after you send the sample for crystal analysis. And can this be a false negative? Of course, you know, it depends. It depends on the technician, but you know, you're relying a lot on their abilities to find them. But it's very hard to miss, because I don't know if you've ever seen in the microscope somebody with gout, like there are millions of these little crystals. So it's very hard to miss if you actually have the crystal deposition disease. Important things to know is that if you have like a typical osteoarthritis, they have very little WBCs, and they're mostly monocytes or lymphocytes. Whereas on the inflammatory arthritis, either septic or rheumatologic in origin, they mostly have polymorphonuclear cells. So you see monocytes or lymphocytes, think about either this is lupus or DJD, primarily DJD, or some sort of traumatic arthritis. So just take a look at the white count. Gram stain in the white count. Okay, who's next to help me?
Okay, 20-year-old woman is evaluated in the emergency department for a one-day history of nausea, vomiting, and blood per rectum. The past several months, she has had fatigue and weakness. 2 weeks ago, she dosed cardiologist with vomiting, including chest pain and abdominal pain. She also has a 1-week history of low-grade fever and worsening of her abdominal pain. This examination, she appears to feel stem height, blood pressure is 145 or 85, pulse rate is 112, and 16. She has an erythematous rash over the cheeks and forehead. Cardiopulmonary examination reveals a friction rub. Abdominal examination reveals mild distension, low bowel sound, and increased abdominal tenderness. The wrists are tender and mildly swollen. Bilateral 1+ peripheral edema is present, and a stool specimen is positive for occult blood. Lab findings are as follows. Peripheral blood smear is normal. Chest radiograph shows a small pleural effusion, and radiograph of the abdomen shows dilatation of the bowel loops without obstruction or free air. CT of the abdomen reveals symmetric thickening of the bowel wall, dilatation of bowel segments, and an increased number of vessels in the cone-like pattern consistent with bowel ischemia. Colonoscopy reveals scattered ulcerations suggesting ischemia. What is the most likely diagnosis?
So from these labs that you skip, so important things to look for is that this is, when you see an ESR this high, you're either dealing with severe vasculitis or osteomyelitis. It's like, in other words, it's very uncommon to see osteo with a very low ESR. Most patients with osteomyelitis, they have a very, very high ESR. So the other things that are important is that this person appears to be hemolyzing, because she has the LDH is high, the haptoglobin is kind of low, and the rectum test is positive, and you see a lot of reticulocyte, I think is a little bit high, and she's anemic. So a lot of pancytopenia. So what do you guys think she has? I mean, it's obviously pretty clear that she has multiple organs, like lupus, right? So Crohn's disease is unlikely to present this way. It's more likely to present just with like GI, bright blood per rectum. Sometimes they have extra-articular manifestations like arthritis, but it's not going to give you this myriad of abnormalities, lab abnormalities. Have you guys seen HUS? HUS, usually in peds. Yeah, in peds usually they see this. I see it in adults once in a while. It's like a form of TTP, but it's less severe. TTP in adults, on your boards, they may give you a patient with the classic pentad of symptoms: altered mental status, fever, thrombocytopenia, hemolytic anemia with schistocytes, and acute renal failure. So in children, they may give you the diarrhea-related HUS, which is caused by E. coli strain. Have you guys remember what's it called?
0157.
OH157, and there is a test that you can assess for in the stool. So if you're admitting someone, you can send it, and it's a pretty sensitive test. But the patients can also have non-diarrheal HUS, and the way these patients present is by thrombocytopenia, anemia, and renal failure. And this is actually a medical emergency because you need to be able to diagnose it promptly and treat them. And the treatment can sometimes involve the use of plasma exchange, plasmapheresis. Have you guys seen plasmapheresis before? Just imagine like a dialysis machine in the hospital, but instead of giving dialysate, which is the replacement fluid that we use, you're trying to remove the pathogenic antibodies by using the plasma exchange machine and replacing it with fresh frozen plasma. So you see, if you ever see a plasma exchange how it's done, you're going to see a bunch of bags of fresh frozen plasma hanging, and these patients get like over 4 or 6 hours of therapy per day. And this is something that you do daily until you're able to. There are different protocols, but until you're able to at least remove the burden of the pathogenic antibodies. If you get asked about TTP on your boards, please do not answer steroids, because they're gonna want to trick you with, what is the most important next step in the management. The most important next step in the management is plasmapheresis. So for TTP, so always remember that. But the other condition that I listed here is the HSP. Have you guys seen HSP? It's like a typical salmon rash in the lower extremities primarily, and these patients can present with renal failure. It's mostly young people or children, and a lot of researchers believe that it's just a spectrum of IgA nephropathy, and because they have the same pathogenic deposition of the IgA deposits in the glomeruli, but typically these patients don't present with GI symptoms. They're more like skin and kidneys and microscopic hematuria. PAN, have you guys heard about PAN? Which is the systemic disease association with PAN on your boards? Hepatitis B. So every time you see PAN, you think about Hep B, and the diagnosis is usually done by doing a renal angiogram. You don't biopsy these patients because they can bleed, they can die from bleeding. If you suspect it, you do a renal angiogram and you can see what we call microaneurysms. So if you see a kidney with a bunch of little dilatations in the arteries, that's PAN, and it's Hep B until proven otherwise. And lupus, we all know the lupus is a great mimicker. In the boards, they may give you something pretty straightforward. The nice thing about the boards is they don't give you things that they may or may not be. They just give you something that is the full spectrum of the presentation. So this person has a lot of the criteria. If you guys remember the MD brain soap, are you guys still getting taught about like malar rash, discoid rash? You guys have the mnemonic MD brain soap. So make sure you know that, because you need at least how many criteria to be able to diagnose it?
5 or 6.
You need at least 4 out of 11. Yeah, so make sure you guys know the 11.
What is it?
MD soap brain. MD soap brain. I mean, you can memorize it, whatever you want to memorize it, but it's important that you guys come up with your own system. Lupus is a great mimicker. It's not syphilis. I think it's probably lupus. I've had so many times where the patients, we have no idea what they have, and the ANA takes some time to come back, and when it comes back, everything is clear. So it's one of those things, like when I was in training, I remember admitting a patient because he kept coming to the ER because he had some sort of itchy skin, and he kept coming in. He got all sorts of products. He wasn't getting better, and the last time he was admitted is because he was having personality changes. And on exam, his skin had like a little bit of like a rash that was like palpable. It was not very evident. Probably doctors that saw him in the ER never really saw the primary lesion, but it was like a palpable purpura type of thing, like a leukocytoclastic vasculitis rash. And he had lymph nodes. And you know, one of the things that you're going to realize is when you get the patients admitted from the ER tells you one story, and the patient will tell you a completely different story. And the reason, and I'm not meaning to blame it on my ER colleagues. I think I respect and I really appreciate the work that they do there. But in the ER, you have to be very fast, and you have to make decisions that are very fast. And a lot of times, these patients, you have to have the time to interview them, get to the bottom of it. So when you're doing your training, your residency, your fellowship, your job is to get a very detailed history. So this person ended up having a lot of things that they never told us. Like he came so many times, blah, blah, blah. We examined him, he had a bunch of lymph nodes, so we did a excisional biopsy. I just called one of the general surgery residents, and he did an excisional biopsy of one of the axillary lymph nodes. And by the time the biopsy result came back, the ANA came back, and he clearly had lupus. And did we think about it? Yeah, we mentioned, maybe this guy has lupus, but just to show you how the spectrum of disease, like it can be something like personality change, or psychiatric manifestations, or some sort of vasculitis. But on your boards, you're not gonna get this mystery patient. You're gonna get everybody with the constellation of symptoms consistent with lupus. Okay, so these are the criteria. So 4 or more of the following. So photosensitivity, it's an easy question to ask. The malar rash. The ulcers can also happen in the genitals. So it's not just oral and nasopharyngeal, so you ask for genital ulcers. The discoid rash, or the erythematous raised lesions. And the organ systemic criteria, you can have arthritis, remember, is non-erosive, is 2 or more joints, and they're symmetrical. Patients can have serositis, either they have like a pericardial effusion or they have pleuritic chest pain. If you have a UA, you're going to see protein in the urine, you're going to see RBCs. They may mention RBC casts. If you see the word RBC cast, that's never normal. That needs to be studied. That needs to be, a person with RBC cast always needs to have a biopsy, because that's almost pathognomonic of glomerular hematuria, and it's a GN until proven otherwise. And you see all these blood abnormalities. It can go from cytopenias to hemolytic anemia to very low platelets, and neuropsychiatric manifestations when it involves the brain. And the immunologic abnormalities criteria, we have the ANA. By the way, can you have a lupus negative ANA?
Yes.
It's very rare, but you can. It's only like less than 1% of the cases. But there's another test that is highly positive, which is the anti-Smith antibody. So it's very unlikely you're going to have a lupus negative anti-Smith antibody. And that's the reason why we send both when we suspect lupus. And if you have anti-double-stranded DNA, what do you think of? Double-stranded DNA antibody? I'm not sure if autoimmune hepatitis, to be honest with you, but if you have a double-stranded, anti-double-stranded DNA, that puts you at risk for renal involvement. So, but I'm not sure. I have to look into it. And the other associated syndrome is the anti-phospholipid antibody syndrome. So they may give you a female that has issues with infertility, have like multiple like miscarriages and difficult to get pregnant, and sometimes they present with some sort of like weird, like say like an arterial thrombosis. Like that's very rare. You're not gonna see like the other day they called me from the ER with a patient with a pretty significant renal infarction. She presented with abdominal pain. They did a CT, and there was a large infarct in one of the kidneys. You either have AFib, you had trauma, which she didn't, and she didn't have AFib, at least that we knew of based on the EKG that we did there, or you had some sort of like hypercoagulable disorder. And it turned out that the lady had antiphospholipid antibody syndrome. So when you see patients with weird like this person had like ischemic colitis, you don't see that unless you have like pretty bad AFib or you have a vascular path, like an extensive, atherosclerotic. Remember, the patient that we were talking about, the atherosclerotic renal artery stenosis. So those patients can have that, but you're not going to have a 32-year-old woman with ischemic colitis. That's got to be coming from somewhere. So, okay, so these are the life criteria, and these are the antibodies and the clinical association. So important things here is that anti-Smith is lupus is almost like 100% specific, but if you have an anti-RMP, you think about mixed connective tissue disease or systemic lupus. The the anti-Rho and anti-LAB, you think about Sjogren's, okay? And anti-phospholipid antibody, you think about lupus. Although you can have isolated anti-phospholipid antibody syndrome without having lupus, and that's exactly what this person that I'm describing had. And the anti-histamine antibody, think about drug-induced lupus. Okay. All right. Why don't you help me with this question?
35-year-old woman with a 3-year history of SLEs admitted to the hospital with a blood pressure of 180/90 and evidence of acute kidney injury. Her last lupus flare was 1 year ago and she is currently asymptomatic. 5 years ago, she developed deep vein thrombosis and pulmonary embolism after an automobile accident. She has had 3 first trimester miscarriages. Her only medication is hydroxychloroquine. On physical exam, temperature is normal, blood pressure is 200/96, pulse rate is 102, and respiration rate is 20. Cardiopulmonary examination is normal except for an S4 gout. Abdominal examination is unremarkable. There is no rash, lymphadenopathy, or oral ulcers. Labs, hemoglobin 12.3, leukocytes 5,300, platelets 122, retic count 1.9%. Creatinine is 3.2. Serum complements are normal. ANA is 11280. Anti-double-stranded DNA is negative. IgM is IgM specific anti-cardiolipin antibody is greater than 100. IgG specific anti-cardiolipin antibody is greater than 100. Lupus anticoagulant positive. Urinalysis 2 plus protein, 1 plus blood, 2 to 3 leukocytes, 2 to 5 erythrocytes for high power field. Urine protein creatinine ratio